so many people here. This is wonderful. So today, it's my pleasure to introduce Dr. David Vossler, who's going to give us a presentation on dementia. This is the first of a two-part series. The second one's going to come next Sunday. Dave, as he likes to be called, is a Clinical Professor of Neurology at the UW. He's also on the Church Council, and Health and Wholeness is lucky enough to have Dave as our liaison, which has been really wonderful and helpful to us. Okay, I think that's about all I have to say. There is, just for your information, there will be an article coming out, most likely in the November trendings now, that Dave has written, that will be kind of a summary, I think, of his presentations this week and next week. All right. I'll turn it over to you.
Well, thank you, Terry. And yes, I like to be called Dave. If I get called David, it's, that reminds me of my mother, and I was in trouble, and which happened a lot, actually. So, rest her soul. All right. Well, it's my pleasure to be here, and so I wanted to kind of talk about dementia. Terry and Cherry too kind of talked to me about some time ago about giving some medical talks, and they asked me to do a couple of different thoughts, things on like dizziness and peripheral neuropathy and things like that are problematic conditions. And then maybe the dementias, and I thought I'd like to do this because vertigo, first of all, vertigo is something that we don't actually do that much as a neurologist. Neurologists, you might think, well, that's a brain problem. Actually, it's more of an ear problem. So we leave that to the ear, nose, and throat doctors. And peripheral neuropathy is, it's hard to treat, and many of the causes we really can't treat, and like diabetes, things like that. So I thought, and that's definitely not my area of expertise. I'm more of a brain neurologist. So a neurologist is a person who takes care of disorders of the brain, but in a medical way, not a surgical way. So I'm not a neurosurgeon, I'm a neurologist. There are many, many more neurologists than neurosurgeons, but everybody, when they hear neurologist, they think neurosurgeon. So I want to understand that I'm a medical neurologist, medical doctor, not a surgical doctor. And we kind of divide our specialty into different parts of the nervous system because it's the most complicated body system that we have, right? There's so many things that can go wrong with the nervous system. And I know many of you have had issues with these kinds of things, so I kind of do from the neck up. I don't do the nerves and muscles, so that's why I'm doing dementia. My area of expertise is epilepsy and seizures. I've been doing that since I came here in 1987 to University of Washington from Boston, and that's my passion. But I will talk to you today about the dementias. Can you guys see these slides okay, or do we need to dim I'm almost wondering if we should dim the overhead lights, but okay. So I like to start with an outline so you know what to expect. And as Terry said, this is a two-part series, so slow me down if I've had too much coffee and I'm going too fast, please, and interrupt me and ask me questions as we go. This is meant to be comprehensive but yet informal. Okay, and so we'll cover all of this stuff, not today, not all today. We'll cover half today, and we'll cover half next week, next Sunday. So you may not know that there are four main types of dementia. There's actually more than that, but those are the main ones, and there's no point in talking about rare stuff. Let's just talk about the main ones. We can talk about the signs and the symptoms of different kinds of dementia because those actually help inform us about which one it is. They're actually different enough that, by taking a history, a neurologist can go, oh, you don't have Alzheimer's disease, you have Lewy body dementia. We also have diagnostic tests that we can use, and we do use, and they're getting better, and to sort of diagnose specifically which type of dementia you have. And why is that important? Why do we have to break these down into the four different types? Well, the treatments are different, right? If you have an infection, let's say in your bladder, you'll do a urine test, submit a urine sample, they'll send it to the laboratory, it comes back, oh, it's E. coli. Well, that's a very different antibiotic choice than if it's Pseudomonas or some other bacteria, right? So, the treatment depends on the exact diagnosis, and we're getting better at diagnosis, and we're getting better at treatment. There are medications that have been around for a while that kind of help memory a little bit, and I think it's like putting whitewash on a fence, that's a wooden fence that's kind of rotting anyway. It's not; those don't really reverse the aging of the wood. But now we have medications that actually treat the root cause of Alzheimer's disease. So, good news, right? It's taken billions and billions and billions of dollars worldwide spent by drug companies. I know I kind of do too, bash the drug companies, right? Because their prices are extremely high. But I will tell you, they have spent billions and achieved nothing for decades. They've been trying. It's not for lack of trying. But finally, we're getting some drugs that work for Alzheimer's disease, which is the #1 cause of dementia. So there's that. But before I go into dementia, I think it's important to talk about MCI. Don't confuse that with the term TBI, which is traumatic brain injury from head injuries. But MCI is mild cognitive impairment. And I can tell you, I recently stopped seeing patients at the end of April, but for 45 years was a practicing physician, and I get people coming in all the time saying, I forget, I lose my keys, I make mistakes, I have this one gentleman, he was a train engineer for Burlington Northern Santa Fe, a very bright guy, in his 70s, retired. He liked to work with his hands in his shop. He would drive around, take his wife to the doctor, the store, whatever. And then he began to have trouble doing mathematical calculations to do his shop work. He also volunteered repairing bicycles. And he also found his calculations were a problem. And then just finding his way around South King County, he would get lost. He's like, I'm a train engineer. I can follow. I was really good at this, and I'm having trouble. And he never progressed over many, many years. And he really fell into this mild cognitive impairment. And some of you may be feeling like, I have a little bit of difficulties with that. And I don't want any shows of hands, by the way. Please don't identify yourself. That's not what we're going to do. But you may notice that. And it can be due to a lot of things. It could be medications that you're on, and we simplified his medicines, and he's a little bit better, but still complains. And that's okay, I understand that. So mild cognitive impairment is not dementia. Okay, it's not necessarily leading up to dementia. It's not like pre-dementia, but it can be. So it's not always pre-dementia, but it can lead to that. Let me read this for you, because I like this description, and these aren't my words, but I modified them. It involves cognitive. We're going to use the word cognitive this week and next week. Cognitive means thinking. It's not just memory, it's all aspects of thinking. So this involves cognitive problems beyond those that you would expect based on a person's age and education. Okay, with age, I'm sorry to say, I'm 67, okay, I'm going to tell you that this is a fact, and we're all going to have to just face up to it, sit up straight and suck it up, because as we get older, we lose a little bit of cognitive thinking ability, and that's normal, okay? Men, our prostates are all getting bigger. Those of us that are getting older, and I'm feeling this too, my knees are not the same at 67 as when I was 27. Really, we kind of peak in our 40s in terms of cognitive ability, but we do gain wisdom, and experience kind of makes up for, some of the cognitive losses we get in our 60s, 70s, and 80s. We had President Biden, we have President Trump, former President Trump, both of whom late 70s, early 80s. Are they capable of doing their job? Are they having some difficulties? I would submit actually both of them. Certainly, President Biden, struggled during the debate, right? And so, there's some issues there. Some of those are age-related. So we have to kind of factor that in. Education plays a role too. The more higher degree of education you've had, you have more reserve. You have your brain is bigger, not really bigger, but it's got more robustness, and it can withstand some of the age-related changes, and it's not quite as obvious. So if you have problems that are beyond what you would expect for age and education, you may have mild cognitive impairment, but they don't interfere with your activities of daily living. You're not having major forgetfulness. It could occur as a transitional stage, into dementia, sort of a pre-dementia, but it doesn't always. It can include both memory problems, but also non-memory problems. So language problems, finding your way, where did I park my car, or even like, how do I get around South King County, like this BNSF train engineer that I had. We don't really know the cause of it. I think in some cases, though, it is a prelude to some of the 4 types of dementia. And about half of the people who get MCI eventually do go on to get Alzheimer's disease diagnosed in 5 years, but the other half don't. And some, it actually can just stay stable, like my train engineer, and then others, it can actually get better. And again, it's important to see your doctor about this if you're concerned. We shouldn't blow it off as doctors. It needs to be addressed. It needs to be acknowledged. It needs to be watched. And other medications and medical conditions. What if it's depression? Depression, by the way, causes a lot of memory problems. Poor sleep, sleep apnea, causes a lot of memory problems. If you can treat the depression, if you can treat the sleep apnea, you're going to get better. You're going to think better. Bad headaches, headache disorders also, and ADHD, attention deficit. There's lots of things that can interfere with our cognition or thinking that isn't dementia, and it isn't even mild cognitive impairment. So what are the 4 types of dementia? I've already mentioned Alzheimer's disease, number 1. I think we all know that. And then we tend to equate dementia with that. But vascular dementia from repeated stroke-like things is the number 2. And then there are some less common types but still problematic, frontotemporal dementia and Lewy body dementia. I'm hoping today, and again, I don't want to talk fast to rush, but I'm hoping to get through number 1 and number 2 today with you. We'll focus mostly on Alzheimer's disease. And next week I'll cover frontotemporal dementia, Lewy body dementia, and then the tests that we do and the treatments that we have today. So there are rarer ones at the bottom that you don't need to know about. I'm going to actually give this talk to some students of mine, but they'll have to know about the one at the bottom. You don't have to know that. And they get tested on it too. So there's no test. There's no quiz here. Does anybody have any questions before we dive into Alzheimer's disease?
I didn't get the 4th one before you.
Sure. It's called Lewy body. Yeah, named after Dr. Lewy. So Alzheimer was a German neurologist who described the pathology of Alzheimer's disease. I want to say in the late 1800s. It's been known for a long time. And I don't know the national origin of Dr. Lewy, but he described it as rare. That's fairly rare. Okay, so Alzheimer's disease is common. Epidemiology means how does this disease occur in the population? Who does it affect? Most common cause of dementia, right now we estimate it's just under 6 million Americans have Alzheimer's disease. That number may triple by 2050, and there's an obvious reason for that. And I don't think this is news to anybody, it shouldn't be. We have an aging population, and I'm in that. I'm on Medicare and Social Security, like everybody else our age, right? An additional 11.6 million have MCI. 2/3 are women, and we don't know exactly the reason why. There seem to be biological factors for that. There's also a longer lifespan, right? Women outlive men. On average, if you're 65 or over, women outlive men on average 3 years. If you're just born, women outlive men. Like if you look at lifespan beginning at age 0, it's a 5-year difference because men die in traumatic, injuries, falls, industrial accidents, those doing stupid things. I would say women are much smarter. It's true. I didn't really realize this, but it's interesting. So Alzheimer's disease is more common in Black and Latino Americans, less common in Asian Americans than it is in white Americans. So we have largely a Caucasian audience. Quick look around the room. We're about kind of in the middle in terms of risk. Incidence. I'm not talking about incidence. Let's talk about prevalence. Prevalence is in an age group, what percentage of people have the condition. Incidence means how many develop it each year. So we'll skip that. That's more for the doctors. Think about prevalence. In our age group, in my age group, 65 to 74, 3%. It's not real high, right? But, and I don't have the 75 to 85 range, but it's higher, of course, there. And then if you're over age 85, it's estimated it's about 47%. It doesn't mean it's severe, but it means, that there's enough there to make a diagnosis. Okay, so what kinds of things cause Alzheimer's disease? You could read the slide, but there's a lot more than we used to think. We used to think it was, first of all, we didn't know for decades. We suspected that their genetics or family history played a role in some cases, not most. There have been cases like in Colombia, there's a sort of a tribe of people, not a Native American, or not a Native South American tribe, but kind of a group of people, an ancestry, if you will, that lived in a rural area. There's a high rate, like 50% of people get Alzheimer's disease. They're much higher than anywhere else. We knew genes could play a role. So that now we know there's over 20 genes. We're not going to talk about these at all today. I don't even want to get into it, but just to let you know, genes play a role. There are also what are called alleles that are involved in cholesterol metabolism, and if you have what's called the ApoE4 allele, one of them triples your risk, two of them increases your risk tenfold. It's not truly a gene that causes Alzheimer's disease, but it's a risk factor. So we don't do genetic testing at this time for Alzheimer's disease, and there's no role for genetic testing at this time. More to come on that. I think, in the decades coming, we're going to learn more. I wish I had a pointer, I don't. High blood pressure, high cholesterol, heart attack, and stroke all raise your risk of Alzheimer's disease. Something we didn't know more than 5 years ago. Sleep apnea, where you stop breathing at night. Insomnia, poor sleep, raises your risk of Alzheimer's disease. Alcohol use, frankly, any alcohol use is a risk factor for all kinds of things. Certainly moderate to marked alcohol use is a risk for Alzheimer's disease, as well as all kinds of things, even cancers. There's been a lot of work on this. The Bill and Melinda Gates Foundation funded the Global Health Burden of Disease initiative. I spent billions of dollars. This was a non-governmental. They just gave the money to University of Washington, which funded this global health initiative, and they've studied all kinds of things. They get data from all over the world. One of the studies they did was on alcohol use. And I'm not a teetotaler, and I'm not suggesting that anybody be a teetotaler. But be aware that what they concluded was the only safe amount of alcohol, if you don't want to get any kind of disease, the only safe amount of alcohol is 0. Okay? It used to be like, a little bit of, French red wine has flavonoids in it, and that's going to reverse your heart attack. That's actually not true. So this study put that to rest. That, if you want to cut your risk to 0, don't drink at all. I like a nice German beer once in a while, right? I'm a Lutheran. Okay. And traumatic brain injuries, even my field, epilepsy, is a risk factor for Alzheimer's disease. And air pollution, interesting enough. So lots of things here. What can we do about this? This is kind of scary, Dave. Come on, you're telling us stuff we don't want to hear, right? Well, okay, so there's some good news. There's some things we can do. Greater years of formal education. I think our congregation is probably has I would say an average, top level of education is probably higher than the average across the United States. It's kind of like Lake Wobegon, everybody's above average, right? Garrison Keillor used to say that. But I think it is true for our congregation. We're probably here in Bellevue, pretty, above average education, and that's a good thing. Doing mentally challenging activities, this is something you can do. There's a debate about things like, Sudoku or crossword puzzles or other types of puzzles, whether that really helps. They haven't really shown that it does. They haven't shown that it doesn't help. What has been shown is doing hard things, going across the street, enrolling in Bellevue College and taking math classes, advanced math classes. Okay, maybe that's not the most fun thing, right? Learning a foreign language. I'm going to go learn Spanish. I don't speak Spanish, okay? Those things that require a lot of hard work, even examination, they have been shown to help. Maybe that's not everybody's cup of tea, but I'm just throwing it out there. What else can you do? Physical activity, more physical activity. We don't want people to have what we call a sedentary lifestyle. In medicine, we call it a sedentary lifestyle, and a lot of us do, right? And now that my darn knees, I used to be a marathon runner, and I can't even go 5 miles now. I can't even go a mile. What is going on here? But do the best you can. Cardio aerobic is best. Okay, if you aren't sweating, if you aren't puffing, it's not good enough probably. A little bit, anything's better than sitting around, so even going for a walk is better than nothing. But try to do aerobic exercise. Talk to your doctor, get approval, have him or her to tell you what are you allowed to do. We have different age limits, age-based limits on our heart rate, right? We can only, like someone at my age shouldn't be going 150, 160 beats per minute. That's too much actually for a 67-year-old heart like mine. Weight loss, we can lose weight, and there's lots of ways to do that. Talk to your doctor. Good quality sleep. This is actually really important. If you are not getting good sleep, you're not cleaning the deposits of these amyloid and tau plaques. I'll talk about this in a few slides. You're not able to clear those out of your brain. Those waste products need to get out of your brain. When do they get out of your brain? When you're asleep. Especially when you're asleep on one side or the other. It helps. There's a drainage system. I'll come back to that. Remember that, because I'll come back to that. Think about cutting down on your alcohol use. Quit smoking if you haven't done so already. And we live, unfortunately, in an area of the country, except with our wildfire smoke these days, but we have pretty good air, especially here in Bellevue, so that's good. Not so for people who live in congested downtown cities. I'm thinking of Los Angeles, smog, bus, diesel exhaust, those things, that contributes to a lot of health problems. Pulmonary problems, asthma, but also dementia, actually, it turns out. Hearing aids and vision correction. If you can't see and you can't hear, and to know what it is, that it contributes to the risk of dementia. And then loneliness and isolation. So, spend time with people. Younger people, if you have an elder with dementia, make sure you're visiting them, taking them on activities, getting out and doing things. Those are really important. All right. Now, we're only going to really talk about late onset Alzheimer's disease because that's 95% of the cases. I do know 2 women who developed early onset Alzheimer's disease. One was in her 50s and one started at about 60. That's uncommon. It's also really, it's hard to see it happen to anybody, but I especially feel bad for people in their 50s and have a 20-year-old young lady that just lost her mom at age 59. That's crazy, but it does happen. More common genetic problems in these cases, and so anyway, we aren't going to talk about those because they're not that common, and we just don't have time to do it. Sometime, maybe another time. Okay, so what are the main symptoms? What happens in Alzheimer's disease? Anybody? What goes wrong? What do you see in a person who maybe you're thinking, I think this person could have Alzheimer's disease? Memory, right? But memory is not one thing. There are many types of memory, and there are many subsets of memory. And memory is not the only thing that occurs. In 95% of cases, it's a deficit in memory, but a specific type of memory, which I'll come to in a bit, I'll explain this. It's called episodic memory. So I'll differentiate episodic memory from other types of memory, because episodic is the one, you'll understand this. Wait for one or two more slides, and you'll understand that better. So 95% of cases, that's the first symptom, right? When do we start thinking, hey, I think, my mom, my sister, my son, whatever, hopefully not my son, my dad is having problems. You usually start thinking that when they're not remembering things, right? But there's other problems, attention problems. So when you can't find your car keys, by the way, guys, where did I leave my car keys, which I do all the time, my future son-in-law left his AirPods at a house we stayed at, several months ago and got them back. But that's just an attention problem. That's not memory. That's attention. That's short term. Like, whoa, what did I do with those? But that can be a problem in Alzheimer's as it progresses. Visual spatial problems. That wayfinding, like I was talking about with my train engineer. I don't know the roads. I go down the road and it doesn't even look. I don't think I've been there before. I can't I can't find the creamer in Safeway. I get creamer all the time in Safeway, and I just can't know where it is. Language problems, those become a problem. Executive functions, we'll talk about what executive function means. And then it can get to a point where people can't recognize family members, and then of course as it gets really bad, they're not able to remain continent. They can't perform activities of daily living, even brushing, combing the hair, going to the bathroom, dressing. Those things can be problematic. Unfortunately, toward the end, as it progresses, depression, apathy, irritability, agitation, and psychosis can occur. And they don't occur to everybody to the same extent. When you get that agitation and irritability, and even sort of seeing things and thinking things that are really not happening there, that's very difficult, as probably everybody knows. When it's very hard for the patient, it's very hard for the person, the family, and the staff that wind up having to try to calm folks down. So what's episodic memory? That is where you remember events, experiences, situations. Let's say you took a trip to the Super Bowl last year, and you watched the Huskies Michigan game or whatever, okay, national championship, and you can remember that. Okay, oh yeah, I was there with my husband. My daughter flew in from Philadelphia to join us. We stayed at the Hilton Garden Inn, and the Huskies lost. Okay, those are episodic memories. Okay, experiences, situations. What happens when you begin to have difficulties? Then you have repetitive questioning. You're misplacing personal items. Neurologists think of that as more like attention, but that falls in, it kind of overlaps, let's put it that way. Missing appointments, paying bills late. Visual spatial, examples of visual spatial problems. Navigation, as I mentioned. Getting lost, this is, someone's in memory care, they wander outside the building and they get lost. They have no idea how to get back to the building. Can't find things that are in plain sight, recognizing faces or objects. I keep thinking of patients I can tell stories about, but we'll never finish if I do that. So, language problems, just can't think of the names of things. And I saw this with my old mom, with my own mom, toward later in her life, as she reached almost 93, she was having trouble thinking of words, and difficulty even comprehending things. Grammar errors, spelling errors, reading, writing problems. When we talk about executive function, that's the front part of the brain, the large frontal lobes of our brain that really are the things that differentiate us from other mammals. We can organize things, we can multitask, we can maintain our attention, we have humor, some more than others. You know, we're attentive, we can reason, problem solve, make decisions. That gets impaired as Alzheimer's disease progresses. And then sometimes you just making calculations or using technology and devices can occur as well. Being unable to log into the computer with your password. I had a Boeing engineer, he was in his 50s, and when the family and he really decided something was wrong, he would go to Boeing and he just couldn't log into his computer. And that was kind of the first thing for him. But he was one of those early onset persons. Unfortunately, it was quite devastating. So again, there are these different types of memory. We talked about episodic, but what about semantic memory? Semantic memory is facts, concepts, meaning with words, general knowledge. You know, where was John F. Kennedy shot? What's the capital of France? What's the capital of Washington State? What's a hammer used for? What is gravity? You know, just kind of general sense. If you let go of something, it's going to fall to the floor, right? That's semantic. You're taught that. You learn that. That's different from episodic memory, things that happen, experiences, stuff like that. That is procedural memory. This is like memory that allows you to remember how to do things. So like riding a bicycle, driving a car, typing on a keyboard, playing a musical instrument. I haven't played my clarinet since I was probably 20, but I probably could still bang out a few notes. It would be good. That's procedural memory. We kind of retain those last two in Alzheimer's disease more than you retain the episodic memory. So have you seen, who was it? Lady Gaga was Tony Bennett. She was she did some stuff with Tony Bennett prior to his passing. And she went to his house, and there was a reporter there, I don't remember if David Muir who was there, went to his house, and he couldn't talk, and he couldn't really, do a lot of stuff. But she, I think I may have the story a little bit wrong, but she got on the piano and started playing some of his old songs, and he started singing, right? He was using that procedural memory. It came back to, and you see that a lot. There's lots of stories like that. Okay, so other problems that can occur, I guess I don't have to read all this to you, but these restless, repetitive behaviors, picking, muscle weakness, this is as it really gets more severe. Poor balance, falls, lack of coordination, loud snoring, gasping for air, dream enactment, so they're dreaming and kind of, doing things. Weight loss of appetite, is sort of seen a lot. And of course, we are, I think, all familiar with the end stages: bowel, bladder incontinence, inability to walk, and just being bedbound. So those are the really true sad things that happen late in the sequence. Okay, well, so what's going on? What causes this, right? I mean, if I have heart disease and my coronary arteries are blocked or nearly blocked by cholesterol and calcium deposits, we understand that's what causes heart disease, right? Causes coronary artery disease. Someone in our congregation just lost a family member to that thing, right? But what's going on here? First of all, the brain starts to shrink, and it tends to shrink in the temporal lobes, which are down here, and it starts to shrink in the occipital and parietal lobes here. Temporal lobes, the Romans thought it was tempus, time. They had something to do with temporary, right? They called it the temporal lobe. They thought it had something to do with memory. Well, they thought it had to do with time, but it actually has to do with memory. Your temporal lobe is the seat of your memory, short-term memory especially. And the occipital lobes are that visual, that's where your vision is back here. So you tend to not see things, visually. You can't find your way, you're getting lost, things like that. So that's where we see the shrinkage, the atrophy of the whole brain. When we say gross, we mean the large brain. In German, gross means large, right? We know that. Okay, under the microscope, really that's where the business end is. The atrophy is because of loss of our brain cells that do the calculations, memories, thinking, the neurons. But within the neurons and around the neurons, you have accumulation of waste products that are sticky. they stick together. They're sugar proteins, amyloid beta 42. It just sticks together. It sticks together in sheets. So one comes up, goes like that, and lays down a sheet. And another one comes along and they auto-assemble. They'll assemble themselves into layers and layers and layers of things until you have the amyloid is collected into plaques like that. This is a fluorescent stain, microscopic stain. Here's a brown stain that's used, and that's the plaques surrounding the neuron. You also have, within the neurons, you have what are called neurofibrillary tangles, or just tangles. And these tangles are also clumps of something, a protein called tau, which has a lot of phosphorus on it, and it's sticky, and it accumulates, and it just kills these neurons. And sometimes along the way you can have some blood vessel changes, but this just kind of goes along for the ride. The tangles and the plaques, since I was a neurology resident beginning 40 years ago at Boston University, we've been talking about this, and that's what Alzheimer described, plaques and tangles, because he could see them in the old days. Now, we need a waste processing system. We need a way to get this stuff out of our brain, and normally that's what happens. And without getting into the weeds too much, I'll just say, you know, that there are two types of blood vessels in our body. The kind that pulsate, right? You can feel your pulse at your wrist. You can do that right now. That's an artery. They're carrying the blood directly from the heart, and that's pulsating. So this is the pulsating artery here, the red, and then over on the other side you have that coming from the heart, fresh oxygen, fluids, etc., sugar to power the brain. And over here on this side you have the veins. It's like the soft veins on the top of your hand. Those are low pressure. They're taking things back to the core of our body for waste processing, maybe to the kidneys or whatever. Well, what happens is that this pulsation here drives a little bit of water through the brain, kind of like a flushing action that's always occurring. But it doesn't occur much when we're awake, like this. It occurs mostly when we're asleep. And it turns out that there are little channels that are called the lymphatic system. This is new information. We've only discovered this in the last 5 to 8 years because they're so microscopic. Nobody could see them until about 5 or 8 years ago. They're extremely microscopic, but they're carrying these fluids in little microscopic channels through the brain. And what they're doing is this is a neuron here. Where is it here? This thing right up here, and then these are some of the processes, the long extensions of the neuron, which allow, that's what communicates. The networks of these things allow us to think and allows me to talk and stand here without falling over. And then you have fluid that's flowing through here, kind of flushing the system. And here's astrocytes. These are supportive cells that support the neurons and help nourish them, and they regulate all this. So there's little amyloid things here and tangles, the tau tangles that are flushed out and are taken out and sent back into the body and eventually flushed out of our system and degraded. What happens is that process doesn't happen so well. And we think that the lymphatic system is part of the problem. It may not be the only problem, but it's part of what's going on here. Not as much fluids coming through. There's not as much waste product coming out. So these waste products start to stick together as tangles and then plaques. And it's during sleep when we're laying on our side, these channels tend to run out from the center of the brain outward. So if you lay on your left side or your right side in my case here, that helps to stimulate that flow. So that may be why we found that sleep is really helpful. I'm going to skip this slide. And now I'm going to talk about imaging. So, Dave, you talked about under the microscope, we could see these changes. You talked about grossly large scale level, temporal lobe, occipital lobe are atrophied or shrunken. Well, can you show us that with imaging? Yes, we can. So you can see here. So atrophy is shrinkage. So here's a very shrunken temporal lobe. You haven't looked at MRIs and you wouldn't know that, but if I showed any of my medical students would go, oh my gosh, that's terrible. Here's some in the frontal lobe too, but in Alzheimer's disease, it tends to be the temporal lobe down here, and then the back of the brain here. You can also sometimes see microscopic blood vessel blockages, even microhemorrhages, and these are other changes that occur at high blood pressure. So those are more seen in the vascular types of dementia, but can be seen overlapping in Alzheimer's disease too. Now, PET imaging, we'll talk about this a little bit more. PET scans a type of radioactive compound that goes in and binds the brain and helps make the diagnosis. So I'll talk about a little bit about this today, and I'll talk more about it next week. It's a type of nuclear medicine test. It's not an MRI scan or a CT scan. CTs are X-rays, MRIs magnetic imaging. This is using a nuclear isotope. In this case, fluoride-18, which is a nuclear isotope. Okay. You can see amyloid plaques with fluor-beta here, which is called amyvid. There's a couple of other compounds too. The early one that was developed was in Pittsburgh, University of Pittsburgh. It's called PIB, but it doesn't matter. We don't use that anymore. These are better. Tau, to look at the tangles, tau imaging can be done, but right now it's for research purposes only. Medicare has said now that they will provide general coverage for amyloid PET scan, not for the tau PET scans, because those are still more in development, but I don't think it'll be long, and I think probably tau is superior to amyloid scans. What this I'm going to show you is the next image here shows what that looks like. So that's using the old Pittsburgh combo, and these are amyloid scans here. And I'll go through the columns in a second. And these are tau scans, what they look like. So here's a person who's normal, thinking normal, no problems. You see in the white matter, which is the deep part of the brain, a little bit of yellow right there. That's normal. That's normal to see that. What you don't want to see is a bunch of red and orange on the outside. Now this cognitively normal person does have that. So it may be that they're on the way to mild cognitive impairment. They seem cognitively normal now, but maybe 5 years from now they won't be. So this isn't really a normal scan, but the person, doesn't have any symptoms. They seem normal for now. These are patients with mild Alzheimer's disease and then severe. And so you see a lot of that red all over the whole brain. And then down here, these are the tau scans, and you see the temporal lobe of the brain is very much involved, and the back part of the brain, as we talked about. So these kinds of scans, in addition to the neurologist getting a good history, doing cognitive testing, we can get MRI and we can get PET scans to make the diagnosis. I'm running really close on time here. Maybe I'll just push ahead a little bit, and then we'll talk more next time, next week. I want to just kind of touch on vascular dementia, the second most common cause of dementia. This is blood vessel problems. So it can be a single stroke or a stroke. By the way, there's two kinds of stroke. There's blockage strokes where the blood vessel gets blocked. That's called ischemic stroke. Ischemia means lack of blood flow. Heme means blood, and means lack of blood flow type of stroke. Or hemorrhages where there's a burst blood vessel and the blood spews out into the brain. And it's usually not one stroke, it's just accumulation of several small ones, and usually with repeated separate ischemic strokes or hemorrhages over time. And there can be small vessel disease changes that cause that, like I showed you on the MRI scan. Neuropsychological testing will show a kind of a different pattern of problems. When you do this cognitive testing, people will have different patterns. They won't have so much memory problems, but they'll have more trouble with the executive function, planning, processing, attention, organizing, and thinking speed is slow. Memory is actually a little bit better retained, but there's not one specific pattern here. The way we can make the diagnosis is usually aided by imaging, MRI specifically. So again, there's this, you can get these blockages, like the kind of cholesterol and calcium plaques that can cause blockages of the heart arteries. It can block the carotid artery. The carotid is the one that goes to the brain, and that can cause a lack of blood flow, and then you get what's called an ischemic stroke. On the right-hand side here, you have like a hemorrhage where this is what happened, sadly, to my father when he was 59. He had a massive hemorrhage like that deep in the brain and was essentially dead instantly. So and these unfortunately do happen. Here's two different images. You can see the white areas here, but they're very, very different because the one on the left is an MRI scan. MRI scan is actually not as good at seeing blood. You can kind of see it in this darker area here is actually a little bit of minor blood changes, but this is, but the white is actually due to a blockage. This is an ischemic stroke, so there's a blockage here. Contrast that over here, this is a CAT scan, which is X-ray based, and this is showing a huge blood clot. This is a big hemorrhage into the brain, like my dad, unfortunately. So these do occur. These are dramatic cases of these kind of things. But I'll just say, what we're dealing with mostly is sort of repeated microscopic, accumulation of these vascular changes. So what can you do here? Well, again, aerobic exercise. What kind of diet has been shown to help prevent strokes? Mediterranean diet, hands down. I mean, that's it. So look into that if you're not familiar with it. If you're smoking, why are you doing that? Quit now. Reduce high blood pressure, diet, exercise, medication, normalize blood sugar, lower your total and your LDL, your bad cholesterol, raise the good cholesterol, which is ADL, diet and medication. See a neurologist for certain vascular medications, aspirin, Plavix, Coumadin, which is warfarin, or some of the, better yet, some of the DOACs, like Eliquis, Pradaxa. We don't use Pradaxa that much anymore, but Eliquis or Xarelto are good at preventing these blood clot type problems. So I know I went quickly. I want to leave 10 minutes for people to get to church. I'm going to leave frontotemporal dementia until next week because it's not as common, and I'd rather take some questions at this time. So what questions do you have? Comments? Okay, I have to ask. Okay, my wife. She always questions me. Go ahead. Stacey, go ahead.
Okay, doctor, why does vascular issues like ischemic or hemorrhagic, why does that lead to dementia? I think we're familiar with, like, if you have a stroke, maybe you can't move part of your body, but why does it cause that?
So Michelle's question is an excellent one, and not just because she's my wife, it actually is an excellent question. Why do these ischemic stroke or hemorrhages cause dementia? Well, it would be kind of like going into the microchip in the hard drive in my computer and just taking out a gigantic sector of it. The computer's not going to work. You've taken out a lot of the calculation, the memory, the speed, it's lost. You begin to lose more and more what you call the functional reserve. You're just taking out chunks. To put it simply. I think you had a question.
Well, in one of your first slides, you said that we had 5.7 million people have this.
With Alzheimer's disease. Yeah.
Mm-hmm. And you said that was going to increase 3 times between now and 2050.
Yeah.
Now, the population could, I suppose, increase 3 times, but you seem to be suggesting the things that are causing this Alzheimer's are going to get worse.
Yeah, I think, no, that's a good question. So he's asking what's going to cause this tripling of Alzheimer prevalence in the next 26 years? That's really what you're asking. Yeah. And I don't think it's so much risk factors. I think it's just our aging population. Baby boomers, I'm at the tail end. I was born in 57, and that's kind of the toward the end, around 60s, around the end, or something, 62 is the end of the baby boom. And all of those people are moving up, right? 57, and if I'm still lucky enough to be alive in 2050, I'll be you know, with a lot old. 93, I'll be 93, right? And we know the incidence or the prevalence is about half of people in upper 90s. So it's just an aging phenomenon. That said, if we could reduce, you know, overweight, sedentary lifestyle, smoking, glucose, you know, all these things, cholesterol, we can maybe drop that. So there's room to improve. But I think it's a demographic and aging issue. Yeah, Janelle.
David, on one of your screens of the MRI, there was a little thing up there with a white matter and it said caused by warfarin. Are there many medications that can cause that thing? I mean, that type of thing?
I can't remember what that one was. Warfarin is, of course, Coumadin is the old brand name and is an older style blood thinner. And it's a very, very tricky drug to use because if you change your diet, you eat less green leafy vegetables like spinach, which has vitamin K in it. Now you're starting to get less vitamin K in your diet. The thinness of your blood, your INR, will go up, and you're at greater risk of bleeding anytime it goes up. Or if you accidentally, did I take my warfarin this morning? And take another dose. I mean, these things happen, right? And we've seen people come in, their normal INR would be like 2.5 range, 2.5. For someone who's anticoagulated, mine is 1, you know, because if you're not taking it, it should be 1. So they're 2.5 times thinner, and we've seen people come in at 9 or 14, and they're having averages. So we don't use warfarin as much as we used to because it's really.
I know, I had a blood clot one time.
Yeah.
They were giving it to me and they were.
Yeah, if you have it in even a blood clot.
Yeah.
And you're every week you're in there getting your blood drawn, and so these DOACs you don't have to do that with, and the risk of bleeding is lower.
Thank you.
Teresa?
I was just wondering about, I was hearing that stress, you know, anxiety, things like that can affect dementia. I don't know if that's it. I didn't see it on any of your lists.
It might, well, if people are stressed or anxious, it could, you know, cause their difficulty, you know, kind of performing, but it's not a risk factor. Good question. Okay, I think one more question and then I'm going to stop and we will continue next week.
You mentioned sleeping. Does it matter? Is one side preferable to another?
No,
You just need to do both.
Yeah. We can't control it anyway. You know, there is absolutely no way to make yourself sleep on your side. But you know, if for some reason you're like trying to avoid sleeping on your side, don't. It's good to sleep on your side, but you're not able to really, you know, unless you're waking up a lot, you're not able to control it. Left or right doesn't matter. Alternating.
It's just cleansing.
Yeah, because those little lymphatic channels run from the inside of the brain out. They run out this way. So if it's down, literally gravity is what's helping to pull that fluid. We think. That's still about. Okay, I think we need to stop because Hamster came